Hello everyone, welcome. I'm Dr. Shariful Halim and today I'm going to talk about basics of calcium and phosphate homeostasis. So let's first start with calcium homeostasis. As you might know that plasma calcium exists in three forms, and among those three forms, the honest form, which is the major portion, which is biologically active, and the other forms are, some forms are bound to albumin, about 40%, which is non-ionized portion, and also some of the calcium is bound to anions, which is also non-ionized portion. And normally there is a balance between ionized and non-ionized portion, and in some situations this balance can shift, and one of the situation is alkalosis. So whenever someone has alkalosis, there will be an increase in affinity of albumin to bind calcium. So the ionized calcium will now convert to non-ionized calcium by binding to albumin. So there will be hypocalcemia. Now let's talk about calcium balance. So calcium balance is actually a balance between intake and output of calcium. So it can be positive, where intake is more, or it can be negative, where loss or excretion is more. Positive calcium balance can be seen in a growing child who is actually developing his or her bones, and that's why they have more absorption of calcium and less excretion, and the abundant calcium is actually deposited inside the bones. And negative calcium balance can be seen in pregnant ladies and also lactating women. Those people actually lose calcium or have more excretion, maybe by placenta or maybe by breast milk, and less absorption in relation to more excretion. So they lose the calcium from bones. So here is a picture which shows you the basic regulation of serum calcium. So the way the calcium goes in and out of your body is like that. You eat food that contains calcium. This calcium is absorbed from your gut, goes to the blood, and then it can either go to bone or it can be excreted through the kidney. So those are the major ways that the calcium can go, and the controller of those ways, or stimulator and inhibitor of those ways, are actually three. One is active form of vitamin D, or 1,25 dihydroxy cholecalciferol. Another player here, or another controller, is parathyroid hormone, and the least important controller here is calcitonin. So the basic roles of dihydroxycholecalciferol and parathyroid hormone is to raise calcium level in the blood. That's their main target. Always remember that. So to achieve that target, they will do anything. Like 1,25 dihydroxycholecalciferol or active vitamin D increases the absorption, increases the resorption, increases the reabsorption. And also the parathyroid hormone, same, increases reabsorption, increases resorption, and indirectly increases absorption of calcium. Indirectly, because it doesn't have any direct effect on the enterocytes. Rather, it stimulates the production of 1,25 dihydroxycholecalciferol, and that's how it increases the absorption of calcium and ultimately would lead to an increase in calcium level in the blood. And calcitonin is a hormone which actually decreases bone resorption, which is actually a bit less important. So vitamin D3 is a major player in calcium homeostasis, and you can get it from your skin after sun exposure, or you can get it from plants. Both of the forms are converted to first 25 hydroxyvitamin D in the liver, and then to 1,25 dihydroxyvitamin D in the kidney. And the action that I have already mentioned, that increases the absorption of dietary calcium and phosphate, that increases the resorption of calcium and phosphate, so they increase the level of calcium and also increase the level of phosphate. And also I didn't mention that they also a bit increase the resorption or reabsorption of calcium from the kidney and also reabsorption of phosphate. If someone is deficient of vitamin D, especially if he or she is a kid, he will develop something called rickets. And in case of adult, vitamin D deficiency will lead to osteomalacia. And vitamin D deficiency can be caused by malabsorption. So you have actually you cannot actually absorb vitamin D, and this can occur in different type of malabsorptive disorders, maybe pancreatic disorder, or even in case of cystic fibrosis. And decreased sunlight or poor sunlight may lead to a decreased production or endogenous production of vitamin D. Poor diet that contains a less amount of vitamin D can also lead to it. And chronic kidney disease, because vitamin D is actually activated, or the active form of vitamin D is formed inside kidney. So if there is kidney damage, kidney can no longer produce a sufficient amount of vitamin D, that leads to vitamin D deficiency. So here is a basic biosynthetic pathway of vitamin D. So you can get it from either diet or you can get it from skin. So from skin, you have something called 7-dehydrocholesterol, which is converted to cholecalciferol with the help of ultraviolet ray. And cholecalciferol is converted to 25-hydroxycholecalciferol in the liver. And this 25-hydroxycholecalciferol has two fate. It can either be active or it can either be inactive. The active form is called 1,25-dihydroxycholecalciferol, and the inactive form is 24,25-dihydroxycholecalciferol. And the formation of 1,25-dihydroxycholecalciferol is stimulated by a low calcium, a low phosphate, and a high parathyroid hormone. So, as I have already mentioned, the vitamin D synthesis is increased by a high parathyroid hormone, a low calcium, and a low phosphate level. And if there is increased production of 1,25-dihydroxycholecalciferol or 1,25-dihydroxyvitamin D, it will actually have a negative feedback on its own synthesis. So there is a basic difference between parathyroid and vitamin D on kidney. So both of them increase the calcium reabsorption, but parathyroid hormone decreases phosphate reabsorption, whereas vitamin D actually increases phosphate reabsorption. So parathyroid hormone will lead to hypophosphatemia versus vitamin D, which will lead to hyperphosphatemia. So here I put something about osteomalacia or rickets, and this occurs due to defective mineralization or calcification of the osteoid matrix. And now the bones are no longer strong enough, so they become soft, and this cannot actually take all the weight, so the bones become bent or they bow out. And in case of osteomalacia or rickets, as there is decreased vitamin D, there will be decreased serum calcium, which will actually lead to an increased parathyroid hormone secretion as a response. And increased parathyroid hormone secretion will actually act on kidney and will lead to an increased excretion of phosphate, so there will be a decreased serum phosphate. And there will be actually hyperactivity of osteoblast, which will lead to increased alkaline phosphatase. So here now we can talk about the parathyroid hormone, which is also a major player alongside with vitamin D, and it's released from the chief cells of parathyroid glands. And the function is increased bone resorption of calcium and phosphate, increased kidney resorption of reabsorption of calcium in the distal convoluted tubule, and most importantly, it decreases reabsorption of phosphate in proximal convoluted tubule. So it leads to phosphate excretion and decrease in serum phosphate. And the parathyroid hormone also stimulates the production of calcitriol, or the active form of vitamin D or D3, also known as 1,25-dihydroxycholecalciferol, by stimulating 1-alpha hydroxylase in proximal convoluted tubule. So the net effect of parathyroid is increased serum calcium and decreased serum phosphate by increasing urinary phosphate excretion. So you can also call it as PTH, as phosphate tracing hormone. I put it from actually Phosphate 2015 edition. And the basic mechanism of parathyroid hormone on bone is like that. parathyroid hormone increases the macrophage colony stimulating factor and also increases the rank L. Rank L means ligand for rank. So this rank L is the ligand which is secreted by osteoblast and osteocyte, and it binds to rank receptor on osteoclast, and binding of receptor for rank actually activates NK-kappa B and stimulates the osteoclast or increases the activity of osteoclast. And whenever it increases activity of osteoclast, it will lead to more bone resorption. So bone will actually lose calcium, and this calcium will get out from bone and come into the ACF and increase the serum calcium level. And in some cases, intermittent PTH or parathyroid hormone release can stimulate bone formation. So regulation of parathyroid hormone is actually done mainly by calcium, phosphate, and magnesium. Whenever there is a decrease in calcium, it will lead to increased parathyroid hormone secretion, easy. And whenever there is an increase in serum phosphate, it will lead to increased parathyroid hormone secretion, which will ultimately reduce the phosphate level by excreting through kidney. And another important thing to remember is magnesium. So magnesium effect on parathyroid gland is actually two types. So whenever you have a mild to moderate decrease in serum calcium, it will lead to increased parathyroid hormone secretion. But whenever that magnesium level is very low, it will decrease parathyroid hormone secretion, and as parathyroid hormone increases blood calcium level, whenever you no longer have parathyroid hormones, there will be hypocalcemia. And decreased magnesium can occur in situations like diarrhea when you lose magnesium, aminoglycosides, diuretics, and also alcohol abuse. So here you can see regulation of parathyroid by calcium. So whenever you have a decrease in calcium level, it will stimulate the parathyroid hormone through binding to calcium receptors in the parathyroid cells, and there will be release of parathyroid hormone in circulation. And the action will be manifold, and one of the action is it stimulates the reabsorption of calcium, and also it inhibits phosphate reabsorption, so thereby increase the excretion of phosphate and decrease serum phosphate level. And another effect is it stimulates the production of active form of vitamin D by stimulating or actually inducing 1-alpha hydroxylase. And whenever it stimulates the vitamin D will lead to an increased absorption of calcium from the gut and ultimately increase serum calcium. So increased reabsorption from kidney, increased reabsorption from gut indirectly. And also it will act on the bone, and as I already mentioned, it will activate the osteoclast, and this osteoclast activation will lead to increased bone resorption and increased release of calcium to the blood. And if the calcium level is high, it will lead to a feedback inhibition of parathyroid hormone. And here you can see the phosphate homeostasis. So whenever you have a low serum phosphorus or low serum phosphate, it will stimulate the formation of active form of vitamin D, which will lead to increased reabsorption from gut and also increased resorption from bone. So there will be increase in serum phosphate level. So another less important hormone is calcitonin. It is actually secreted by the peripheral follicular cells of the thyroid gland, and it opposes actions of PTH, especially PTH action on bone. And you can remember it by calcitonin tones down calcium level, and the major function of calcitonin is to decrease bone resorption, and thereby actually it normalizes or decreases serum calcium level, because you no longer have an increased supply of calcium from the bone, so serum calcium level comes down. And it is regulated by increased serum calcium. So whenever there is increased serum calcium, it will stimulate the release of calcitonin. And you can also use it to treat hypercalcemia, because it will actually trap the calcium inside your bones. And so in summary, which is very important to remember, in summary, the major players of calcium homeostasis in your body are parathyroid, vitamin D, and calcitonin. The major sites of action are bone, kidney, and intestine. So, parathyroid hormone is actually stimulated or secreted in whenever you have a low calcium level, and this low calcium level will stimulate parathyroid hormone secretion, which will actually ultimately result in an increase in calcium level through action on bone by increasing resorption, action on kidney by increasing reabsorption, and indirect action on intestine by activation of vitamin D. Now comes vitamin D. So the signal for stimulation of vitamin D is also low serum calcium. So whenever you have a low serum calcium, it stimulates the formation of active form of vitamin D, which will ultimately lead to a rise in calcium like that of phosphate, like that of parathyroid hormone. And it occurs by the same type of mechanism, like it increases the resorption of calcium from bone, increases calcium reabsorption from kidney, and also increases calcium absorption from intestines through something called calbindin D28K. So ultimately increases serum calcium. And calcitonin is secreted whenever you have an increase in serum calcium. So remember, parathyroid hormone and vitamin D is secreted whenever there is a decrease in serum calcium. Calcitonin is released whenever there is increase in serum calcium, which will ultimately lead to a decrease in serum calcium after calcitonin is secreted, and it occurs by decreasing resorption of bone, meaning that the calcium is trapped inside the bone. So now comes the phosphate. So the phosphate controls the secretion mainly of vitamin D. So whenever you have a low serum phosphate, it will stimulate the active form of vitamin D, and this stimulation will lead to an increased formation of vitamin D, which will ultimately increase the serum phosphate level by increasing the bone resorption, increasing the reabsorption of phosphate from kidney, and also increasing the absorption of phosphate from intestines. So ultimately increasing the phosphate. But parathyroid hormone has the exact opposite effects on phosphate, especially on kidney. So the parathyroid hormone decreases the reabsorption of phosphate from the kidney. So as there is a decrease in phosphate reabsorption in the kidney, it will ultimately lead to a reduction in phosphate level in the blood. So parathyroid hormone reduces phosphate in the blood, so serum phosphate reduces ultimately. So parathyroid hormone causes hypercalcemia, vitamin D can cause hypercalcemia, parathyroid hormone causes a hypophosphatemia, but vitamin D causes hyperphosphatemia. So the main difference, the only difference is phosphate. Parathyroid trashes phosphate. Parathyroid gets rid of phosphate. Calcium preserves phosphate. And calcitonin is on calcium. Calcitonin reduces serum calcium. That's all from me now. Thanks for watching my video.